Okay. Thank you guys so much for coming. Yes. Oh, good idea. Thank you, Lauren. I really am so happy that you guys are here tonight. So I know that the title of the presentation was like addiction and the opioid crisis. Well, I never put the word addiction in my presentations because I want people to come. And unfortunately, that word can shut a lot of people off. So what I'll be talking about tonight is a lot about opioids and their effects on the brain, including how the brain becomes addicted. So I am a therapist by trade. I do a lot of research on different risky behaviors and treatments for risky behaviors. I work with students and kids of a lot of different ages, starting at around age 9, going all the way up to adult. And so the perspective that I'm coming from is really from a therapeutic perspective. And so we'll learn tonight about the brain as it's growing and developing. And then we'll talk about some things that you can do to prevent some of those things, as well as questions that you guys may have. So I want to start off with, I think the first thing I have is a video.
Well, my son was snoring kind of funny, but he seemed to be okay, so I left him and went to work. They reckon he died about an hour later.
If someone has taken drugs like pills or alcohol and are making unusual snoring or gurgling sounds in their sleep, they may be overdosing. Try hard to wake them. If you can't, call an ambulance immediately.
If I'd known, he'd still be alive today.
So August 30th was Overdose Awareness Day. I'm not quite sure if anybody knew that. It makes me really sad that we have a day that is named for honoring overdose victims. But I also wanted to put up here that we have a fantastic partner in the community called the HEROES program with the University of Texas Health Science Center. And so a couple of colleagues that we have worked with and some addiction researchers work there, and they have a fantastic outreach program. If you don't know about it and you know someone who needs help with opioid addiction, the HEROES program is the place to call. I'll talk more about that at the end and what they do so that you guys know that. And if anybody needs some information about Overdose Day and some of the videos that they've put out, there's the website for that as well. So, yes. The HEROES program is really an opioid emergency management, and they're studying that, and they have a really fantastic outreach team. One of the most difficult things to do for clients who have opioid addiction is to come in for treatment. And so what I love about their work is that they go out into the community and outreach. So yes. Okay, so let's talk a little bit about opioids. We know that about 130 people in the United States die every day from an opioid overdose. And this includes prescription and illicit opioids. My statistics for this came from the CDC. What we also know is that among insurance and Medicaid enrollees, nearly all heroin overdoses had at least one healthcare encounter in the past 6 months. And so this is data that we actually have from insurance companies and Medicaid enrollees. So this doesn't include a lot of people out there who actually are uninsured. But from what we know about that is that we actually get to see them a lot in presentation at ERs or at hospitals or talking to their healthcare providers. And so we're missing some things. Now, this is one of the most interesting charts that I've seen in a while because it gives you a timeline of our opioid epidemic. So please know that I study high-risk behavior really for a living, and I focus on about 18 different high-risk behaviors. And so I look at charts like this all the time so we can see what's happening in trends. Now we know that alcohol causes about 100,000 deaths a year from not just alcohol-related accidents, but from alcohol-related illnesses as well. Well, opioid epidemic is on the tail of that, with about 70,000 deaths attributed each year now. Now, what you can see according to this chart, is that this first wave here was a rise in opioid prescription overdose deaths. And so in purple, what you see is a really steep increase starting in about 1999, really peaking in about 2010, and then going up a little bit more in 2015, and now it's flatlining. And what you see actually is in 2018 and 19 is that flat line is decreasing just a little bit in some states. And then other states, it's actually increasing a little. This orange line indicates the second wave, the rise in heroin overdose deaths. So this is the rise for prescription, and then this is the rise for heroin overdose deaths that really started to increase steeply in 2010. So what happened between here and there that heroin overdose went up? Well, what we see is that a lot of people are getting more and more addicted to prescription opioids. But in about 2010, we started to see a lot of legal intervention. Our states started to wake up. The DEA started doing raids on doctors or pill mills, and it all of a sudden became very difficult for addicts to actually get prescriptions. And what do we see is that they turn to the much cheaper alternative in heroin, and you start to see immediately overdose deaths increase. And now they're really at parity here. Then we've got our third wave, a rise in synthetic opioid overdose deaths. And you can see that right in about 2013, we see it really go up. So synthetic opioids include things like tramadol and fentanyl. These are prescribed or illicitly manufactured. And a lot of these are much, much more potent. And so what we want to understand here is what's going on that these are increasing. And what we see is that a lot more people are not only having difficulty getting prescriptions for kind of average opioids, but they're going towards doctors that would prescribe them something even more potent, or getting them off the streets. So unfortunately, this is on the increase. These are staying pretty steady, but we're seeing mortality rates that are just really off the chart. Now, this is so interesting because really starting at around here, when we started really understanding kind of the peak of this, is when I started asking physicians. Every time I'd meet a doctor, I would ask them, tell me, how much education do you get in school about addiction? And this was the answer that I got. Oh, maybe about 15 minutes. Or none. I was astounded by this. I would do presentations at schools just about the neuroscience of addiction, and I'd have physicians coming up to me and saying, I'm not really sure what to prescribe. Like, some of the journal articles say it's okay, and some of the drug reps are telling me that I can prescribe it in 30, 60, 90 days, right? So people are coming in for maybe mild dental pain and getting a 90-day prescription for OxyContin. Like, these are really crazy, but the doctors were really confused and trying to figure out, what information is good information. And then over the past 6-7 years, there was a really great article in the New York Times. It was probably about a 50-page article online about Purdue Pharma, which is the maker of OxyContin? Yes, okay. I'm getting confused, my drug's confused. In that article, it was really interesting to me that they described years of bribing and skewing research results. So professors that we kind of trust to be non-biased researchers, unfortunately, were having research funded by people like Purdue Pharma and some of their subsidiaries. And so I looked at a really beautiful body of research that went in to actually count how many research studies that were done on opioids or even other kinds of things like vaping and alcohol, some of the other things. About 23% of all that research had been funded by these large pharmaceutical companies. And when the researchers looked at the findings of those research studies, the larger percentage of them, up to 90 to 92% of those funded articles, actually were pro the drug, right? Go figure. So they bought some research, and then they took that research into the doctor's offices. They really armed their drug reps with this, what looked like non-biased data, and educated physicians on what was healthy to prescribe. They even had a hand in some of the committees that were formed to decide what the next iteration of the DSM, the Diagnostic Statistical Manual of Mental Disorders. And so, when a new issue of the DSM comes out, which is pretty much the Bible for diagnoses, as you learn as a counselor how to diagnose, you learn it from the DSM. And we're currently on the 5th edition, and every time they create a new edition, they form all these committees. And so what I learned is that a lot of pharmaceutical companies actually put physicians onto a lot of those committees because they wanted to make sure that opioid addiction was something that was actually classified as a non-medical condition. That it was actually, you could get addicted to opioids psychologically, but not necessarily physically if you took them as prescribed, which is really, really kind of crazy because there really is a difference between a psychological addiction and a physical addiction, but they actually occur simultaneously at the same time in two different parts of our brain. So, scary things happening. What's really interesting is that we're starting to see that medical schools are actually adding in addiction classes, which is wonderful. And as a matter of fact, up until 2 years ago, addiction, that class, was an elective if you were becoming a master's levels clinician. It was actually an elective. 2 years ago, the national boards that give accreditation to universities who produce master's levels counselors finally made it a mandatory class. And so what that means, though, is that we have generations of clinicians that are practicing out in the world, mental health clinicians, who've never taken a class on addiction. And yet we have anywhere between 30 to 80% of clients who walk into a counseling clinic who have either a primary or a secondary diagnosis of an addiction. And so we've been really undereducated and duped by a lot of big pharma companies, which have created this opioid epidemic. Okay, I could talk about that for a long time, but I'll keep going here. When we talk about opioids, we want to distinguish that from opiates, and you may hear them used interchangeably, but opiates actually are derived from naturally occurring substances. I just love it when kids say to me, but marijuana is natural. And I'm thinking, yeah, and so are a lot of other really heavy drugs that we have out there in the world, like opiates. They're derived from the poppy plant. But interesting too, you guys may see pictures of the poppy plant, on the wall. We actually had, in a treatment center that I worked at, we had this beautiful picture of a field with poppy flowers all over it. And one of our clients asked us to take it down because he was an opioid addict. And I thought, oh my God, that kind of makes sense. It may have triggered somebody, exactly. But really, it comes from the naturally occurring opium, morphine, and heroin and codeine are actually derived from this. And then if we actually create the substance in a lab synthetically, we get opioids. So these are opiates that are also combined with synthetic opiates like Vicodin or Percocet, oxycodone, or fentanyl. Now, it's important to remember that these definitely are naturally occurring substances, but when we start to synthesize them in a lab, we can actually genetically modify them, molecularly modify them, so that they become more and more potent, as in things like oxycodone and fentanyl. Okay, so if we take a look, this is a really interesting picture because it illustrates how much of the drug is equal to its counterpart. So heroin, which is the naturally occurring substance from opiates, this teeny tiny amount of heroin actually is the same potency as this teeny tiny amount of fentanyl, which is a very powerful synthetic opioid. And then you can see this tiny little speck of carfentanil, which is equal to the same potency that are in these two. Carfentanil's been plaguing police departments across the country. And unfortunately, police and first responders. So my husband is a first responder. He's a paramedic. And I always worry about this with him too, but he's really great about wearing gloves. But it's really important because just one tiny speck of carfentanil could cause an overdose or put somebody into a critical condition. And so synthetic substances are so much more, or can be so much more potent. And what we also see is that somebody who becomes addicted to heroin, who may want to purchase something like these things so that they can get high faster or in a more potent way, are in 100 times more overdose danger when they do that. Okay, let's talk a little bit about where they're coming from. So this is interesting to me. Only about 10% of opioids are actually prescribed, purchased from drug dealers or other strangers. About 50% of non-medical users, so these are recreational users of prescription opioids, get them from friends or relatives. And about 25% actually get their prescriptions from physicians. And this is about 2015 data, so it's kind of relatively on time. Now, of course, despite the often cited problem that patients obtain prescriptions from multiple prescribers, most receive the prescriptions from about one doctor. This is actually the case for a lot of other illicit prescription medications, like, for instance, marijuana in some of the states where it's legal. You see that the majority of prescriptions come from very specific practitioners. The kind of typical scenario that you might think of a drug seeker who goes to multiple doctors happens less and less today because a lot of the reporting systems that doctors have access to. They can go into the medical healthcare, the electronic healthcare system to find out if people have a history of drug seeking. So you're seeing that less and less and less, which is driving people who are already addicted more and more to family, friends, relatives, and to the streets.
Can you talk a little bit about these pain docs and how they are?
Oh, well,
Get into that later.
you know, are you thinking of a specific thing that you want people to know?
No, I mean just,
Okay.
as you're saying, 10% of prescriptions, 25 from physicians. So.
Sure. So when, pain docs, or AKA drug dealers, it's pretty interesting. There's been a couple of good Dateline episodes that have gone in and done stings on them, and they know how to operate quickly, going out to the streets and finding a lot of different people who can come in, wait in line, get the prescription, go out. They're pill mills. And what's really nice, though, is that the DA has been really cracking down on that, especially in states where the prescription laws are a little bit different, like, for instance, Florida. A lot of raids. Cody, wasn't there something recently in the news?
Yeah, Florida, yeah.
Yes. Do you remember what that was? I don't remember.
I think they arrested over 200 people connected with pill mills and other such opioid issues.
But these are actually MDs who go and take one little course, pay $10,000 or whatever they pay, and they become pain managers.
Sure. So there's a course that you can take to get certified to become a pain specialist or a pain management specialist, and then actually prescribe.
So wouldn't you say that group of physicians, MDs, have helped fire
They do, but I've got to say that it's actually a smaller percentage than we think. The bigger issue is the uneducated body of physicians that prescribe too much. So like just for instance, my husband was going in for a knee surgery and he asked how many, like what do you prescribe and how many? And the surgery center physician said, oh, I'll give you a 90-day prescription for hydrocodone. And he said, appreciate that, but no thank you. And actually was able to say, this is how many I would like. I'll take 10 for a 3 to 5 day supply. So this is a physician who has obviously known about the opioid epidemic, but is still prescribing a 90-day 4 to 6 pills per day prescription for a very simple outpatient knee surgery. Ugh. Right, so, and he thinks that he's doing something medically sound and not doing any harm. So that's what we really see when we look in the literature as the bigger issue, and that has caused more people to become addicted to opioids quickly than go through.
He's doing that because he's not educated.
Exactly. And the reason that he's not educated is what I talked about before, is because his medical school didn't give him that information. It's interesting because physicians are usually trained to manage symptoms. And so that's why a lot of times you'll see that they won't really have the big picture of how addiction works in the brain and body, because they're managing or chasing symptoms. And so the second piece of that, though, is that when they are physicians, they've gone through all their residency, they've set up, hung a shingle in private practice or working at a clinic, where do you get your education once you're out?
On the street.
Well, you get it from continuing education, right? And so if you want to get your CMEs, your continuing medical education units, you will go to conferences. And who's at those conferences? There are drug representatives, pharmaceutical companies that have these research papers that say, look, it is safe to prescribe 90 days of medications for this issue. Your client or your patient won't get addicted physically to this at this level. That's the bigger issue.
So you'll talk a little bit more about how some of us can get addicted with one pill.
Yes.
And others it might take.
Yes, and that's where we're gonna go next, actually. So let's jump into that. Okay, so this is what I've studied for my entire career. And I really had kind of a fun story about learning this, because when I started out in school, it was in 1989, 1990, when I started my bachelor's. And when I was going through the 90s, that's when all of the literature was finally being published about where in the body addiction lives. And then they started taking a look at genetics and what that looks like as well. And so longitudinal studies that were tracking kids over time were trying to find out, what are the effects of starting, who is showing up in treatment centers, who gets addicted the most. And it was quite interesting. I started having a lot of parents that asked me the question of, is it really so bad? Is it so harmful? I started using here or using in high school a little there. But what you really need to know, and the way that I answer that question, is that 90% of adults who grow up and get diagnosed with a substance use disorder, opioid or anything else, started using the substance in their teenage years. What's going on in adolescence is rife for the creation of addiction. Now, opioids are a little different than that, though, because you can become addicted to opioids. Of course, you can become addicted to most things at any point in your life. But if you start using as an adolescent, your chances significantly go up. If you use any substance before the age of 15, you add about 28% risk on to your genetic risk. We'll talk about how that is a bit later. But if you delay until you're 21 to use substances, you almost completely ameliorate your risk. So when I saw this chart, I could not believe this downward slope is almost absolutely perfect. And I thought, what is going on during this stage of development, or during these ages, that actually can completely inoculate somebody, or almost, from addiction? And really, it was all about what's happening in the brain. This is a study that was done in 1999 with functional MRI technology by Dr. Jay Geed, who took pictures of healthy kids as they were growing and developing. As a matter of fact, 2 of his kids are in this study. It's really neat, though, because he wanted to make sure he ruled out subjects who had mental health issues or substance use. So these are pictures of kids' brains that are really quite healthy as they go through development. And you can see that the part of the brain that's really growing and developing is right here in the front, known as the prefrontal cortex or frontal lobe. When we're little, we have a frontal lobe, but it's just really primitive and underdeveloped, which is cool because we rely on our parents' frontal lobes anyway, right? Then we hit about age 12, which puberty moves us into another stage of brain development, stage 2, where our frontal lobe really starts to explode with growth. And what's interesting about this is that at about age 12, we have about 10 to 15% of what will be our adult brain capacity. When we're about 16 years old, we've got about 45 to 50% of our adult brain's thinking capacity. Isn't that scary? What do we do at age 16? We start driving with half a brain. Right? But then we get to about age 20 and we've got about 80%. That means we have a whole 1/5 of brain development to go between the ages of 20 and 25, when our frontal lobe is actually completely grown and developed. So what's actually going on here is that we are growing a couple substances. Let me show you. This is a picture of an infant's neuron magnified. As this infant grows and develops up to 2 years of age, you can see that the coating that coats the neuron, myelin, is thickening. The thicker our myelin, which is a fatty substance that covers our brain cells, the thicker the myelin, the faster we think. And then the second thing that's growing are those dendrites that reach out to other cells, making long pathways of neuronal connections in our brain. This is what we want. We want really thick connections and pathways. This is all based upon the principle, use it or lose it, which basically says if you use those neurons, they grow long strings, lots of dendrites. So even though our brain peaks at about age 25, with certain skills, we grow dendrites for the rest of our lifetime. Dendrites are really the hardware of learning. Every time you learn something new or practice something, you grow more dendrites that reach out to other cells. When you don't use those cells, they literally get pruned away. And so where I see that happen a lot is with parents who may overfunction for their kids, right? If we do too much for our children, then they develop long strings of neurons for dependence on us, rather than long strings of neurons. Oh, I hope it's nothing I said, you guys.
No, my mom fell. I forgot.
Oh, I'm so sorry. Okay, well, we're videotaping this, so catch it on. We are, so you'll be able to catch it online. Okay, I hope she's all right. These are the skills that our prefrontal cortex, our frontal lobes are in charge of, and the 2 phases of brain development. We've got early phase 1. These are the lower level basic executive functioning skills that our brain grows and develops during elementary and middle school. These are the ones that kind of get us up in the morning, help us remember our lunch, get us oriented to the world. And then when we start to go through middle school and high school, we start to develop higher level executive functioning skills. And so these are the ones really that we need to grow up and become fully self-supporting relational adults, really successful. But unfortunately, these are the ones that start to suffer because of drug and alcohol use. Because about 90% of adults who grow up with substance use problems begin using in their teen years. And that can have a deleterious effect on that part of the brain. And so, well, I've given you a little bit of a kind of a primer on brain development. I want to answer this question specifically about addiction. Is how do high-risk behaviors, drug and alcohol, technology addiction, pornography addiction, there's a lot of addictions that we can contend with today, but how do they affect the brain as we're growing and developing through that really critical pruning process? Has to do with the limbic system, which is where addiction lives. Now we know exactly in our body where addiction causes structural changes. Two little teeny tiny organelles inside the limbic system, the nucleus accumbens and the ventral tegmental area. Those are the two organelles that actually have structural changes that occur when we expose that part of the brain to too much dopamine. And so I want to focus really on the pleasurable experiences part. Now, our limbic system does two major things for us: fight or flight, survival. But it's the pleasurable experiences that we'll focus on today. And that really has a whole lot to do with a lot of different neurochemicals, but they all end up in either an increase or a decrease in dopamine. So a lot of drugs of abuse, opioids, cocaine, alcohol, a lot of things out there will have different effects on different receptor sites or areas in our brain. Like, for instance, marijuana affects almost every single part of our brain because it affects the cannabinoid, the endocannabinoid system. We have cannabinoid receptor sites all over our brain, whereas cocaine primarily targets the limbic system organelles, specifically those that increase dopamine levels. Each drug does something completely different. Alcohol has a really huge effect on GABA receptor sites, but what all of them have in common is that they will cascade through these different neurochemicals and hormones in different parts of our brain and body, and here in the nucleus accumbens cause an increase in dopamine. And so really, neurochemically, what we get addicted to is dopamine in just various intensities caused by a lot of different substances or behaviors. And so if we take a look at what dopamine does for us, it actually is the neurochemical of reward. So our brain gives us a signal when we're doing something good for our survival. And when we do, it makes us feel calm and happy. So when there's something in our environment that is salient for our survival, dopamine will tell us. So an example about that is, how do you feel when you haven't eaten anything for about 6 or 7 hours? Forgot lunch. How do you feel? Grouchy, irritable, hangry. I think it's so funny that we get mood symptoms when we're hungry. But think about this. Your limbic system, it's depleting itself of dopamine. It's basically saying, hey, you need to go do something good for my survival. And until you do, I'm going to make you feel really uncomfortable. And then as soon as you eat, your limbic system says, you just did something good for your survival. Here's your reward. And it gives you about 100% increase in dopamine. When human beings engage in sexual behavior, we get a dopamine increase of 150%. Scientists believe that this is a behavior that's not only good for our survival, but good for our species' survival. So we get more dopamine. And we're all adults here, right? So I can tell a funny joke. If you think about it, like, that's really a great date night right there, right? Okay, good. Y'all laughed at my sex joke. I can always tell how my audience is going to land by that joke. It's really interesting. This is just really normal human behavior, right? And your brain tells you when to engage in something, hopefully when not to. But if we add in drugs of abuse, if somebody snorts a line of cocaine about this long, they get a dopamine increase of 350%. If they use a similar amount of methamphetamine, a very potent stimulant, they get a dopamine increase of 1,100%. Heroin, the natural opiate, if they ingest heroin, they get a dopamine increase of 1,300%. So that study came out a few years ago, and when I read it, I was like, oh my God, I gotta go add this to my graph. So I go in and I added heroin, and then you couldn't even see food or sex anymore. And I thought, that is what happens, isn't it? Like if somebody starts getting addicted to heroin, what's one of the first things they stop doing? Eating.
That's why they're all skinny.
Very. And another thing that happens is they stop having sex. They stop having relationships. They stop engaging in relations. It's so interesting because that limbic system, it's just a reactor. Now remember, the part of the brain that actually thinks and feels and connects, that's the frontal lobe. The limbic system is a simple reactor. It does this very basic calculation. It says, hey, when you put this in my body, I get 250% more dopamine than when you put that in my body. So that must mean this is 250% better for my survival. Your limbic system simply gets hijacked. Alcohol increases dopamine levels by 225, 250%. Marijuana, 225 to 250, 275 if it's the hash oil product. So you can see that there are some drugs that take longer to get addicted to, and some drugs that you can get addicted to the first, second, or third time using them, like meth and heroin. They make structural changes to your brain once you go over the threshold. So let me explain that real quick. Everybody's brain has what's called a hedonic threshold. And that's really kind of a line that we're not supposed to go over. It's just our body's natural leveling out of dopamine. And so here it is. We go up and down with dopamine all day long, right? You get hungry, your dopamine plummets. Your brain says, go get some food. You eat, it goes back up. If you get lonely or bored, you may go to the gym or call a friend or have a conversation, visit somebody. Just face-to-face time increases dopamine levels. Eye contact increases dopamine levels. One of the reasons that scientists believe we have more depression and anxiety than we've ever had in our culture right now, especially with our kids, is because of this. What are kids doing more of today? Right? Exactly. It's really what they're doing less of. So the millennials had 1 hour a day less human contact than my generation, the Generation X. Generation Zs, which are our young kids now, they have 2 hours less human contact per day than my Generation X did. Wow. So they're not getting enough dopamine that comes from all of these kind of natural healthy things. So their dopamine levels are quite low. But if you go above your threshold by drinking too much or using a substance, 2 things happen that are pretty amazing. So the first thing, we travel deep inside the brain into the limbic system. So that's where it is. And when we look at the neurons that are producing the dopamine levels, when you ingest a substance that causes the neuron to produce more and more dopamine, it actually damages the neuron and damages its ability to produce enough dopamine. This is why as high up as you go is as low as you go, because of that phenomenon. So that can damage the cells that are in there and hamper their ability to make enough dopamine, which is one of the reasons why we sometimes put addicts on an antidepressant while they're getting sober, is to help their mood. Because if you're not making enough dopamine, remember, dopamine makes you feel calm and happy. And so if you're doing things to make you feel calm and happy, like eating and hanging out, and your brain is not giving you enough, you need some help. Mm-hmm.
I was going to ask you about Parkinson's.
Oh, which is in the opposite direction, right? Because Parkinson's is very sensitive to dopamine, and we actually give L-Dopa, right, to substitute, because in Parkinson's they're not quite making enough, right? Exactly. So, yes?
Over what time span is that phenomenon you just took us through?
Sure. Of that occur. It depends upon the drug, right? Okay, so alcohol is so interesting to me because we have the liver that helps us with alcohol. So when you ingest 1 serving size of alcohol, your liver can help you process it out of your body before it spikes dopamine levels too high in your brain. But if you binge drink, like if you go over 4 drinks in one sitting, if you're a girl, or 5 drinks if you're a boy in one sitting, then your liver gets pooped out, right? And so you get an influx of dopamine coming in, and that is when we go above our threshold. So you can actually do that to your brain in one sitting. But let me show you the second piece, which will really put together, I think, what you're thinking. The second structural change that happens to the brain during addiction has to do with making new structure. So on every neuron, we have little receptor sites that take up and bind the dopamine. So so this would be a dendrite with receptor sites on it. When you flood the system with too much dopamine, the dendrites actually learn, and they grow more receptor sites. More and more receptor sites for dopamine. Then the dopamine leaves the system, but now you've got all those extra receptor sites in there, and what are they doing?
Begging for more.
Begging for more, wanting more. We call that process that you just saw tolerance and craving. These are new brain structures. So with alcohol, like depending upon how much you drink or how often, it could literally take decades before you have 1 too many receptor sites that move you into tolerance and addiction. Or if you're a regular binge drinker, it could take months or a year.
That's why it's such an insidious disease.
Exactly.
And it takes forever, even for the person
Yes,
suffering.
exactly.
Agree that they might have a
No, because we don't have a test that can go in and count how many extra receptor sites you have and say, oh, nope, too many, because each individual is different as well. So I would guess that it looks really differently individually. But these are new brain structures. You can't uncreate brain structure. Once you make it, you made it. That's why we have a saying, once an addict, always an addict. Now, what is beautiful that happens, thank God, I'm a person in long-term recovery. And so when I got sober, this process happened to me. What happens is that all those extra receptor sites in there, when they're not being used, they kind of become inactive. And I kind of think of them as they're like dried up, right? And then what's really kind of nice is if you really never use them again, they'll break off. Literally, they atrophy and you lose them. But for most of us who have overused substances, we've made so many hundreds of thousands of them that not all of them break off. And because dopamine is always in our system, we're always using some of them. Now, when they become inactive, we can actually go back to baseline levels of dopamine. We can even potentially get off the antidepressant and go back to making sure that we're in recovery, we're getting lots of good, healthy dopamine from our fellowships, from our recovery, from our good relationships, from healthy activities. But what if, this is a true story that happened to me. I was about 6 years sober and I went to Vegas and I watched one of the videos that they have in the room that teaches you how to play craps. And so of course I knew exactly how to play and went down, right? And I hit like 4 or 5 sevens in a row. My table was erupting with jubilant laughter and excitement, and they're raking all of these chips toward me. And you guys,
Dopamine.
oh my God, flooded dopamine. And guess what I started wanting? Cocaine, which was my drug of choice that created all those extra receptor sites in the first place. Isn't that wild? I walked away from that table. Thank goodness somebody said, cash out now. I walked away from that table and I thought, I can never do that again. Because dopamine is dopamine is dopamine, whether you get it from pornography, from sex, whether you get it from food, whether you get it from heroin. It's all different levels of dopamine, right? And once you have too many receptor sites in there, you could activate them quite quickly. That's why when people relapse, especially after long periods of time, within 2 weeks, they can go back to the same tolerance level they had 10, 20 years ago. So scary. Those are extra receptor sites are just lying in wait. Now, you guys, this is the hedonic threshold for most of us. But let me ask you guys, who in here knows that they have genetics somewhere in their family tree for addiction? Okay, it's probably about right. About 1 in every 5 of us do. And the genetic risk could be anywhere from 30% up to 74.4%, depending upon how close the person is to you. So that's not your hedonic threshold if that's you. This could potentially be your hedonic threshold. What we know now today is that people who have the genetic predisposition have something called RDS, Reward Deficiency Syndrome. The seminal paper came out in 1996 by a geneticist named Dr. Kenneth Blum. Anybody heard of him? He actually taught at UT, almost his entire UT in Austin. But it's so interesting, nobody's ever really heard of him because geneticists publish their articles where? In genetic journals. And people like me, who have masters and PhDs in counseling, I read counseling and psychological journals. Oh, well, the cool thing is I also study this. So I was able to find him, and I actually have spoken to him on the phone several times, but he actually was able to find 1,500 different genes that have what's called polymorphed. They're polymorphisms. So they've just changed over time and that are linked to addiction. You can actually get your genetic score read today to tell you what your genetic risk is. So I know my genetic risk is high. I've got about a 7-8 number, which is actually pretty high on the scale. So it's really neat. You just get a mouth swab, $200. You can get your genetic test read. You can get your kids' genetic tests read so you can find out which kid actually got it. It's a company called Genus Health. Actually, Dr. Blum started it. I have no affiliation with him. Genus, Gene, so Gene, US Health. Really great tool, and they send you a wonderful report that shows you which neurochemicals in your brain you actually make a little bit less of. So think about this, you guys. If dopamine is the neurotransmitter that makes you feel calm and happy when you do normal good things for your survival, and your body doesn't make enough of it, how will you feel?
You'll be seeking through other modalities.
Sure. In the big book, it says restless, irritable, and discontented. And when I read Dr. Blum's seminal article, there was all this genetic, all these big words I had to keep looking up. And then it gets to this little paragraph that says what it might look like in the behavior of someone that has RDS, Reward Deficiency Syndrome. Angry, irritable, restless, discontented. You guys, oh my God, I started to cry. Because when I grew up, I felt that way from the beginning. And it made me feel like I didn't fit in with my family, with people. Nothing that I did, I could ever feel really okay about. And I always, guess what, blamed who? Me. I thought I was like damaged. Something was wrong with me. And when I read that article for the first time, I went, oh my God, I am kind of damaged, but it's not like my fault. It's my genes, right? I was already predisposed because I have 2 first-degree relatives who have the genes for addiction. I've lost my favorite uncle from cirrhosis. Another uncle is actively using. My mom has mental illness. My dad was an active addict his entire life. And then I start using before the age of 15. So if you actually calculate my genetic risk plus my environmental risk, I am 102.4% chance of growing up and becoming an addict. By the time I was 12 years old, that was my risk. Wild. So basically, if you have those polymorphisms, your threshold is lower. That means even if you drink or use the exact same amount of dopamine as other people, your brain will start making those structural changes faster than somebody else. Does that make sense? That means that you can kind of keep up with all your other friends and they won't suffer any consequences, but you will start creating cravings and tolerance faster than other people. And here's what it looks like. This is a functional MRI slice looking this way, but we're looking from the top down. The colors indicate blood flow and electrical activity, and what you see is somebody who's had a picture taken 1 second apart, so you can a little see over time. This person is stone cold sober. This is what all of our brains probably look like right now, right? Because we're all stone cold sober. We've got blood flow and electrical activity connecting all parts of our brain. But yet, somebody who's been binge drinking, which is this guy right here, what you'll notice is the limbic system is lit up, full of dopamine, and yet the frontal lobes, off. They shut down. Your body has been tricked into thinking that you just did something good for your survival. So you don't need to anymore. Like, think about how you feel after you overeat on Thanksgiving. Anybody in here overeat on Thanksgiving? Nobody in there? Oh, everybody. What do you feel like doing after you overeat on Thanksgiving? Sleeping. Do you want to have deep problem solving and compassionate, empathic conversations? No, because your frontal lobe is off. Your limbic system says, you're going to keep me alive for like the next 8 hours. Enjoy, feel calm and happy. But what if you're between the ages of 11 and 25 and you're trying to grow your frontal lobe? Does it get to grow if it's off? No. We call that arrested development. If you start using here at 12 and you keep going till you're 25, your frontal lobe won't look like that. It may look more like this. And if you're a regular user, it may look more like this. Quite scary. And if you keep doing that past the age of 25, your executive functioning skills, instead of peaking here, they'll peak here, and the frontal lobe will be off more often than on. And remember, the frontal lobe does higher level executive functioning skills. The frontal lobe connects to other people, has empathy, can attune to people. Every single one of you knows somebody that has this. It's a term that's used, interestingly enough, by the medical community to describe an alcoholic or an addict whose frontal lobe has been off or is currently off because of alcohol or drug use. When your frontal lobe is off because of substance use, this is what you look like. And some of you guys may have known somebody who's been in a car accident and had frontal lobe damage. This is what they look like potentially too. They lose the ability to actually connect humanly, attune to other people. They start to blame, shame, project out onto you. Lots of emotional extremes, denial, anger. The good news here is that you've got that word there. So when somebody gets sober, right, and their frontal lobe starts to turn back on, because if I go back to this picture, oh wait, I think I've got it. Oh, there it is. This shows us how long it takes to heal. This is a cocaine abuser about 10 days sober, and you can see that the limbic system is still on in detox, frontal lobe still off. because it's screaming out for that drug it thinks it needs to survive. And here, the same person over 3 months, 100 days sober, you can see that we got about 50% of the lights are turning back on. It takes about 18 months for this person to return to normal levels of functioning. 18 months, which is really interesting to me because our recovery at 1 year of sobriety, our relapse rates are 50%. That's amazing. 50% of us go out at 1 year. And they usually go to Mexican restaurants and celebrate with margaritas in my practice, which is crazy to me. But it's really interesting. At the 18-month mark, we actually give a chip for 18 months. Relapse rates drop down to the 20th percentile. Oh my God, why such a big drop? Well, you're looking at this brain at 18 months, whereas it's this brain at about a year. And for opiates and opioid addicts, 4 to 5 years. 4 to 5 years before returning to this level of functioning. This is why relapse rates are so much more astronomically high for people who struggle with opioid addiction. Can you imagine what it's like, life on life's terms, when your brain looks like that for 4 to 5 years? I mean, it's hard enough already. Okay, so lots of different things out there. Spiked dopamine levels. I look at things like alcohol. This is two 15-year-olds, a non-drinker versus a heavy drinker. You can see that this kiddo has a lot more activity, but if you can also look closely, this kiddo has more brain development. As those long strings of neurons grow, the brain kind of compacts in on itself and makes all those folds. You can see this happening for this kiddo, but not for this one. This kiddo admitted to being a heavy weekend drinker 2 to 3 days a week, every week for 2 years, from 13 to 15. You can see the arrested development. And for marijuana, this is a SPECT scan, so it shows you brain connectivity. And this a nice healthy scan will be nice and smooth. All the brain cells are connected. Thank you, Cody. These two kiddos who have been using marijuana for a long period of time, what you see is it kind of looks like holes, but they're just areas of the brain that didn't get connected. Especially here. What part of the brain is this? Frontal lobe. Arrest. And so for opiates, this is an interesting, so this shows you like a normal healthy brain, our limbic system kind of sitting back in there, and what you can see right there, it's kind of lit up. Our limbic system is inside, and so what you see is that this person's spree scan in healthy brain is, this is a very calm person who's feeling safe, life's okay, the limbic system is on, but not activated, right? And so for an opiate-induced serotonin deficiency, what you see is that the limbic system is on and overactive. What's interesting here, this part of the brain here, the anterior cingulate, its job is to keep the frontal lobe connected to the limbic system, regulating the limbic system. And when the system is overtaxed by drugs and alcohol, what it does is it keeps the fight or flight system always on, stressing the system out. High levels of cortisol, which create serotonin deficiency, dopamine deficiency. And so this is what this person's looking like for 4 to 5 years while their brain heals. Really, really activated, fear-based activated system. Okay, lots of different behaviors out there that also spike dopamine levels. I think I just popped one of them in here to give you an example. So this is a picture looking from the back forward of somebody with no food addiction, no eating disorders, right after they ingested sugar. Our brain loves sugar. It spikes dopamine levels. So you can see the kind of different parts of the brain that light up. And they compared this to a person who'd actually been in recovery from a food addiction for about 20 years. She relapsed for this study. She ate sugar, had not eaten sugar for 20 years. And here's what her brain looked like after she ate sugar. Now we're looking from the back forward. You can see the limbic system on both sides here. Her poor brain is just lit up. Remember all those extra receptor sites that were inactive? They all just pop back up.
Would you say sugar is more addictive than cocaine?
Oh, yes, no, yes, no. I mean, it depends, because if you think about it, it's the same structure. So when I was getting my doctorate, I actually did a paper on food addiction, because back then, the food researchers weren't talking to the addiction researchers. Oh my God. So I'm reading all these papers on food addiction, and they're all talking about the limbic system and dopamine. And I'm like, why aren't y'all citing these guys? Because they did this research already. What? You know? So, same thing. Okay.
Same thing with people who jog a lot. It's addiction, it's opiate addiction.
So opiate, right, because your body, when you exercise a lot, your body increases endorphins and enkephalins, your body's natural opiates. Really interesting, when you're addicted to nicotine, nicotine tricks your body into thinking you're exercising, so it also increases endorphins and enkephalins, as well as dopamine, glutamate, adrenaline.
But as a society, we look at those kinds of things as healthy, right? Oh, he jogs 6 miles a day.
It is healthy.
Yeah.
If you're jogging potentially 6 miles a day. Part of the problem is if you're jogging 6 miles a day 2 to 3 times a day, every day, then, right?
Well, you're running until you get your endorphins to drop, right?
Well,
Or you're not
it
finished.
depends on how exactly on the person, how many extra receptor sites you've got in there, whether you built a tolerance and you're having craving or not.
Yeah.
So you guys can see all these wonderful neurons connected, right? This is what I think about when I'm doing therapy with clients. Is I'm thinking, okay, where are your pathways short? Let's work on those and get you more connected, because we grow dendrites for the rest of our lives. The more we reach out to other cells, the better. So going back specifically to opioids, here is a list of the best evidence-based treatments for opioid addiction. And this one is really popular right now. MET stands for Medication Assisted Treatment Services. So we have things like Narcan, naloxone, methadone, Suboxone, and Vivitrol. So these are all medications that actually bump out the molecule or the neurotransmitter from the receptor site. So they actually block the effect. Like if somebody's overdosing from opioids, they have too many opioids in the system that are binding with the receptor sites. One shot of Narcan will actually bump out all of the opioid and block the receptor site. So unfortunately, when somebody gets a shot of Narcan and they wake up from an opioid overdose, they're automatically in withdrawal. And that's painful. So what we're seeing with Narcan is it's called the Lazarus drug, because it wakes you back up from the dead. And as soon as you do, you're in withdrawal, so you go score again and use more and overdose and potentially die, or you get another shot of Narcan and you're starting to develop a tolerance level for Narcan. So sometimes people need 2 to 3 shots in one sitting to actually wake them back up. So Narcan can save your life, but you need treatment right away from that. There are some other medications that do some similar things. Like I work with a lot of people who are in recovery from alcoholism, and they take a Vivitrol shot or a pill that helps them to bind to those certain receptor sites that help with withdrawal symptoms, which is wonderful. Well, when you're talking about DTs, delirium tremors, it's a really a high level withdrawal symptom that you see in later stages of alcoholism. So withdrawals that are that level, we would probably want a hospitalization or a detox with a Librium medication, which is a benzodiazepine that helps people who have DTs. So we want to make sure that our treatment spans that 18-month mark, and with opioid, we're looking at 4 to 5 years of treatment that one needs to maybe finally maintain long-term sobriety. Oh, here's the the relapse rates, and it shows you where the big drop is after 18 months. Recovery is definitely a long-term process. And then this is just the last slide. This is the HEROES team over at UT. And this team, they partner with the hospital systems, the HRC Recovery Center, the police, the county and the city, and the fire departments to actually mobilize as a team to respond, which I just love. And so they've got a paramedic and a recovery coach that go together to an addict's house. Once they've been on record, like maybe for a Narcan injection, or they've had a treatment episode at a hospital, Shenandoah Hospital, their record will go to HEROES, and they'll be able to go out and to do outreach. So if you actually need them, you can call them and ask for help as well. This is the last slide here. I always end on this because, you know, I like to focus my attention on adolescents, because I'm trying to prevent them, and I'm empowering parents to try to delay substance use, because as a parent of a teen, your job is to protect that frontal lobe so that it can grow up and be fully self-supporting and not live in your house anymore, right? But live out there successfully. And so if you'd like a copy of my slides so you can see some of my references, some of them are there. And then Cody told you about the wonderful things that we do here at the Hope and Healing Center. And something that I'm extremely grateful for is that they are supporting me in a 2-year fellowship to write a prevention guide for parents. That is called, ta-da, the Neuro Whereabouts Guide, which is a neurodevelopmental guide for parents that shows parents how healthy brains develop, how addiction happens. So what I shared with you guys is in the book. And then there's an elementary, middle, and high school chapter which show parents graphs about which high-risk behaviors pop up at what times out of 18 different ones, and everything that prevention science says can prevent those things, starting really, really early. And then there's chapter 6, which is full of scripts that parents can use. So if your snarky teenager says, "Oh my God, it's a medicine, everybody does it," you'll know exactly what to say to that snarky teenager or college student if you're at that age. Or it could be a great gift for your grandkids, right? So I am about 80% done with this. I'm writing it in infographic style because, as you guys know, a lot of people don't like to read today. So minimal text and lots of fun graphics that might also be appealing to teenagers. But I'm at about 80% right now, done. So my goal is to finish it by December. It's got a lot of graphic design work to it, so we're working on doing that. But if you'd like to have my slides or get on the email list, if you want to know when it comes out, please feel free to send me an email. I'll send you the slides, or if you have questions, let me know.